Hello, everyone. Welcome to today's webinar, New Alzheimer's Disease Treatments, a virtual question and answer with Dr. Turner from Georgetown Memory Disorders Program. If you are new to Insight Memory Care Center, we are a nonprofit organization based in Northern Virginia. Our mission is to provide specialized care, support, and education for individuals in all stages of memory or cognitive impairment, their care partners, and the community. Our vision is a community where those living with memory or cognitive impairments and their care partners can achieve the highest quality of life. Insight has a variety of different programs and resources for the individual with the diagnosis, the care partner, and the community. Our programs include care programs, on-site and virtually, education opportunities, and support programs. I would like to invite Amber Nightingale to the screen from AARP Virginia, today's sponsor for the session. Hi, Amber.
Hi, thank you, Lindsay, for having me. As Lindsay said, I'm Amber Nightingale with AARP, and I'm here in Northern Virginia, and I want to welcome you all to today's program. Since our founding in 1958, AARP has fought to improve the life for all Americans as we age. And today, dementia largely impacts the community that AARP serves. We know that dementia is increasing in frequency around the world as the global population ages. The dementia crisis doesn't just affect those who are affected by the disease. It takes an enormous toll on families as well. And we know that brain health is hugely important at AARP. It's one of the top concerns that our members tell us about. So that's why we are delighted to be able to partner with Insight Memory Care Center on today's program. And it's just one of many programs that we've partnered with them to bring to our members. So I thank you. I hope that you find value in the conversation and that it helps you feel more confident and in control and secure as you grow older. So thank you all for joining us.
Thank you, Amber. Yes, for today's virtual Q&A, I know it's been quite an exciting couple of years with the developments in research for people living with Alzheimer's disease, particularly in the early stage or with mild cognitive impairment. And I know at Insight, many of our families have questions about some of these new treatment options and wondering which may be a good fit for them, the risks, and lots more questions. So I'm going to invite Dr. Turner from Georgetown to join us. And for all of you who are listening in today, please type your questions into the Q&A section of Zoom, and we will get to as many of your questions as we can. Dr. Turner will give us a short presentation to give us all on the same page and give us some basic information, but we will then take ample time for questions and answers. We will have the slides available as well, so no need to frantically take notes on what you see on the screen. Those slides are available and will be sent out to those who registered for today's session. So I will turn it over to Dr. Turner to pull up his slides and give us a little bit of background information on Leqembi and other developments in research.
Well, thank you, Lindsay and Amber, for the invitation. And this is supposed to be very informal, so please send your questions in the chat, and we can have questions during the presentation. We can have questions after the presentation, whatever you would like, and feel free to ask anything you'd like to. So I'm going to start with a few slides just to get the ball rolling. And I'll share my screen. So this is me. I'm a professor of neurology at Georgetown, director of the Memory Disorders Program. Here's my email if you feel like you're too shy to ask a question in the chat. And this is our website, memory.georgetown.edu, where we try to keep up-to-date information posted. And today I'm mostly going to talk about lecanumab for the treatment of mild cognitive impairment and early Alzheimer's disease. So this is our program. This is me. I work with an incredible set of colleagues. We're very skilled and dedicated in discovering new treatments for mild cognitive impairment and Alzheimer's disease. And you may have seen these curves before, but this is what happens with aging. Everyone starts out normal, and then we have this preclinical phase, and then people move into mild cognitive impairment and dementia. Of course, not everyone. but many people will move into these different categories. And the difference is this is normal memory. Mild cognitive impairment means memory problems, but not sufficient enough to impair function. So you can still function, but you do have some memory problems greater than expected for age. And then when the memory problems also impair function, then you cross over this other line into the dementia category. Now we have a whole different things of that are changing over time, and these are called biomarkers. And one of the first biomarkers is amyloid accumulation in the brain that we can detect in spinal fluid or by PET scans, imaging of the brain. And the first thing that happens is amyloid accumulates with aging and then sort of plateaus. And we can see this by doing a lumbar puncture and looking at amyloid in spinal fluid or doing an amyloid PET scan. And you can see it takes 10 to 20 years, maybe 30 years of amyloid accumulation in order to get memory problems. And then this triggers other pathologies, other dysfunction that we can see in the brain. And eventually this causes memory problems. And then this progresses on to functional problems. So these are the different biomarkers. The fact that the first one that becomes abnormal is amyloid suggests that amyloid is causing the disease and causing all these other pathologies, including tau pathologies. So those are the famous Jack curves. These are what these PET scans look like. So here's a normal person, maybe 65 years old. This is an amyloid PET, and this is a tau PET. And you can begin to see these yellow-red regions here, and this little bit of yellow here. These are the amyloid plaques and neurofibrillary tangles of Alzheimer's disease. This is still very early, very mild, so mild that the person is clinically normal, and these are called negative studies, negative amyloid PET and negative tau PET. But the amyloid continues to accumulate slowly over many years, and then you see pictures like this. A lot more amyloid and more of the tau pathology as well, starting to escape into other regions of the brain. This person is still clinically normal, completely normal memory. So, but this is what we call preclinical Alzheimer's disease. Now we're going to say this is a positive amyloid PET scan and a positive tau PET scan, even though the memory is still completely normal. And then there's more amyloid and more tau pathology as time goes on. And then this is a person with dementia due to Alzheimer's disease with much more amyloid pathology and more tau pathology. So when I talk about amyloid PET scans and tau PET scans, this is what they look like.
Dr. Turner, quick question that came in. Is a PET scan the only true way to detect MCI and dementia?
Well, MCI and dementia we detect by clinical testing, by cognitive testing, looking for memory decline and functional decline by different scales. MRI scans will not see the amyloid and the tau pathologies. MRI scans are usually normal for aging in the early stages of Alzheimer's disease. So the only way to see the amyloid is by doing a PET scan or by looking at the proteins in spinal fluid, by doing a lumbar puncture. And the same thing for the tau pathologies. We have to do a tau PET scan or look at the tau proteins in spinal fluid. But the actual syndromes of MCI and dementia, you can detect by cognitive and functional testing, clinical testing. But to get to the accurate diagnosis, then you need the PET scans to find out the cause of the dementia. So today I'm going to talk about these antibodies, particularly lecanumab. So the MAB at the end means monoclonal antibody, and there are several of these different antibodies that have been tried. The first one to get FDA approval and Medicare coverage is lecanumab, and that's also called Leqembi. And it binds to this form of the amyloid and helps the brain and the body remove it from the brain and the body. It helps the body to clear the amyloid from the brain. So amyloid is a protein that's made all the time by all of our cells, and it degrades into this fragment called amyloid. But this changes its shape and begins to aggregate and begins to precipitate in the brain tissue as these big amyloid clumps. And this is what you see on the amyloid PET scans with Alzheimer's disease. So you can think of this as this form of amyloid maybe like water vapor in the atmosphere, is just kind of there all the time, background, you can't see it, but it begins to form clouds or fog as it aggregates into these bigger forms. And then eventually it keeps aggregating until it forms raindrops. So you can think of the amyloid plaques in the brain as being like water vapor, invisible, causing no problems, turning into clouds and fog, and then eventually raindrops. And that's kind of the same process that happens with aging and Alzheimer's disease. So the antibody binds to these amyloid aggregates and helps the body clear it. And that's why we think it causes clinical benefit. So this is a measure of amyloid in the brain. So this is time 0. This is someone with early Alzheimer's at the beginning of a study, and then we start treating with the antibody, and the antibody is removed from the brain. So the amyloid goes away, dissipates, the antibody helps clear it, and you go from a positive amyloid PET scan to a negative amyloid PET scan in the treated group, compared to the placebo group, which is shown here, where the amyloid just continues to gradually increase and increase over time during the course of the study. So this would be what would happen to amyloid in someone treated with placebo, and this is what happens to amyloid in someone treated with Leqembi. So the amyloid is cleared from the brain. Once the amyloid is cleared from the brain, then we allow an additional time in the study for these curves to separate. And these are curves of cognitive function and functional abilities. So you can see this is the beginning of the study and this is the end of the study. So this is worsening. So everyone got worse during the course of the study, but the placebo group got worse along this trajectory and the treated group got worse along this trajectory. So at the end of the study, there was a significant difference. There was much less worsening in those who were treated with the drug, the antibody, compared to the placebo. And that's what we're measuring with the clinical trials. Of course, this comes at a cost, and there are some side effects associated with these antibodies. And one of these is called ARIA-E. E stands for edema or fluid or swelling. We can see this on an MRI scan. For example, here's a patient who developed additional swelling in the brain as a result of Leqembi treatment. All of this white stuff here is fluid or swelling. It will go away, it will dissipate over 1 to 2 months. It's reversible and it will go back to looking like the normal brain tissue shown over here. But this is an example of ARIA-E. And here's a more subtle example with fluid accumulation here. And the other side effect is ARIA-H, or hemorrhages, usually microhemorrhages, meaning they're about the size of a head of a pin. And all of these black spots here are microhemorrhages. So this is an example of ARIA-H. These are very small, very tiny. They're actually smaller than they appear on the MRI images. But they do accumulate with aging. They accumulate with amyloid in the brain, and they accumulate even more with these antibodies. And they're often found in regions of ARIA-E. So this is the edema shown here, and here are these microhemorrhages shown here. Now the microhemorrhages leave sort of a permanent blood stain on the brain, so they never go away, they never disappear. They just sort of accumulate over time. And here's a more subtle example. Here is another microhemorrhages. At the surface of the brain, it's called a siderosis. But again, it's just fluid escaping from the blood escaping from the small blood vessels in the brain. And again, usually so small, they don't cause any clinical signs or symptoms, but we can see them very clearly on the MRI scans. So this study, published this year in New England Journal, asked the question, is Leqembi safe and effective for individuals with mild cognitive impairment or mild dementia due to Alzheimer's disease? So almost 6,000 people were screened to find 898 who got lecanumab treatment and 897 who got placebo. Most did not have enough amyloid in their brain to qualify for the study, which was good news. And this is what the groups looked like. On average, they were about 71 years old. They were about half male and half female, different ethnicities and racial groups. And they were very mild in their diagnosis. Mild cognitive impairment was the majority, and mild dementia due to Alzheimer's. was the other group. So this is very early in the course of Alzheimer's disease. And these are different cognitive and functional scales, such as the Clinical Dementia Rating Scale, the ADAS-Cog, ADCOMS, ADCS, Activities of Daily Living Score. These are just different ways to measure memory and cognition. And from all of these scores, for example, the MMSE, a perfect score is 30, these individuals got about 25 points out of 30. So you can see they're very early, very mild in the course of their disease. And what happened with the lecanemab treatment? Again, this is the scales that we use, the Clinical Dementia Rating Scale, the ADAS-Cog, the ADCOMS, ADCS, Activities of Daily Living Scale. These names are not important. What is important is that there was a significant difference with a p-value showing statistical and clinically significant differences between those treated with lecanemab and those treated with placebo. So those treated with placebo declined at the anticipated rate, and those treated with lecanemab declined less compared to those who were treated with placebo. And this is a measure of the amyloid burden. And with the antibody, about 59 centiloids of amyloid was removed from the brain. So they all started out about 70 or 80, 90 centiloids, and 59 centiloids of amyloid was removed, and nothing was removed from the placebo group. This is shown better in graphical form here. So we start with the amyloid PET scans. So here is the beginning of the study, and here is the end. And the placebo group, the amyloid just continued to accumulate over the 18 months of the study, whereas those who got the antibody treatment, their amyloid was removed up to about 50, 60 centiloids of amyloid by the antibody treatment. So this is given IV every 2 weeks during the course of the study, and the antibody was very effective in removing the amyloid from the brain. Did this turn into a clinical benefit? Yes. So here's the placebo group declining at the anticipated rate, and here is the treated group declining less. So this is about 27% less decline in the treated group compared to the placebo group. And if you draw a line back here and then drop it down to this scale, you can see there's about 5 months less decline in the treated group compared to the placebo group. In other words, the placebo group declined about 18 months worth of decline, as we would expect, whereas the treated group declined about 5 months less on all of the cognitive and functional scales. It doesn't really matter which one you look at. You see a benefit of treatment over placebo in this scale, in this scale, and this scale, and even more of a difference in the Activities of Daily Living score. And this is a measure of, can you use the stove, can you use a telephone, things like that, to measure this Activities of Daily Living score. So even more of a benefit in this scale with the treated group compared to the placebo group. Now you
Dr.
notice,
Turner,
yeah.
Was there any difference in effects between men and women?
There may have been some differences between men and women, but there really weren't enough individuals in each group to really answer that question. It may have been slightly better for men compared to women, but we don't really know for sure. We would have to enroll even more people in the study to properly answer that question. But it's a great question. And you can see that nobody improved. Nobody got better during the course of the study. Everybody got worse. But the people who got the treatment had 5 months less worsening during the 18 months of the study. Now we think and we hope that these curves will continue to separate even further as we move on, and we're collecting these results now, because this is our first disease-modifying treatment of Alzheimer's, whereas the traditional drugs are symptomatic. They have some benefit in memory and function, but they're not really affecting the underlying disease, which is the accumulation of amyloid. Now the antibody is removing the amyloid, so we think it will have more of an impact as we go further beyond 18 months, but we won't know until we collect those results. And of course, as I said, there are risks associated with these antibodies. There's not only inconvenience, there's an IV taking about 1 hour every 2 weeks to get the treatment. And there are some risks, and these are mostly ARIA-E, the edema or the swelling, which was found in 12% of the treated versus 1.7% of the placebo. So some risk of ARIA-E or swelling or edema. Now, most of this was asymptomatic, only 1 to 2% showed any symptoms. And if you did have symptoms, the most common was headache. And the ARIA-E was usually temporary, resolved over time. And the other side effect is are these small hemorrhages, microhemorrhages, found in ARIA-H was found in 17% of treated versus 9% in the placebo. So you can see that even without any treatment, these microhemorrhages accumulate with aging, but you see even more with the antibody treatments. And again, these are usually small, asymptomatic, and we see them on MRI, but usually doesn't cause any symptoms. Now, there have been some symptomatic ARIA-E and ARIA-H events, and more serious, causing more serious symptoms, having to stop the medication either temporarily or permanently. But that tends to be relatively rare. The other interesting fact that we've learned is that there's this gene called ApoE that comes in 3 varieties, 2, 3, and 4. ApoE4 increases risk for Alzheimer's disease, but ApoE4 also increases risk for ARIA. So you have either 0, 1, or 2 copies of ApoE4, and you can see how the risk of ARIA-E increases as you increase the number of ApoE4 genes, shown here. So this is a non-carrier, 5%. This is a heterozygote, so 1 copy of ApoE4 is 10%, and 2 copies of ApoE4 is about 32%. So we do want people to find out and know their ApoE genotype before treating with lecanemab so that we can have a better discussion of the risks of ARIA-E and ARIA-H. So again, the risk of ARIA-E and ARIA-H increase with every copy of ApoE4. We don't really fully understand why this is, but it's been seen with this antibody and many other antibodies as well. This paper talks about who are the best individuals to get lecanemab treatment, the appropriate use criteria. So first of all, we have to make a diagnosis, and we make a diagnosis of either normal aging or mild cognitive impairment or dementia. And then is it dementia due to Alzheimer's disease? In order to call it dementia due to Alzheimer's disease, we have to show that there's amyloid in the brain, either by amyloid PET scan or spinal tap to measure amyloid proteins. And so if someone meets criteria for MCI, meaning cognitive decline worse than normal aging, but not bad enough for dementia, or mild dementia, meaning an MMSE score of 22 out of 22 to 30, the perfect score being 30. So again, very early, very mild in the disease course. MMSE scores 22 to 30 to define mild cognitive impairment and mild Alzheimer's disease, with evidence of amyloid in the brain. And there are other criteria as well. Positive amyloid or spinal fluid, as I mentioned in the study, people were 50 to 90. So outside of that range, we don't really have any information. So it's up to the clinician and the patient. Other medications are okay. These new medications were used on top of the old medications. So these are the old ones that we've been using, the oral pills we've been using for 20 years, donepezil, rivastigmine, galantamine, memantine. So these new antibodies can be given on top of these older treatments. And someone should have a family member who can help with all of the appointments, because there's an IV infusion every 2 weeks with lots of MRI monitoring and clinical visits. So it's a lot to keep track of. So if someone with a normal memory could help, then we would like to have what we call a study partner, or a partner, a family member usually, to help with all of the coordination. Other criteria for getting the Leqembi treatment: if you have more than 4 microhemorrhages on your MRI scan at the beginning, a baseline, then you don't qualify because we think there would be too high a risk for hemorrhage. And so there are certain criteria that we look for on the MRI scan. So we need an MRI scan just before starting Leqembi, but we'll accept one, either 1 year, up to 1 year before starting, looking for microhemorrhages in particular. And then also relatively medically stable, not severe depression. If you have any other immunologic disease, you might be disqualified, or if you're treated with another antibody, you might be disqualified. If you have a bleeding problem, might be disqualified, or on blood thinners, might be disqualified because there might be too high a risk of a hemorrhage from the antibody. So lots of criteria to get the antibody treatment. And we start here, and there's a lot of MRI scans monitoring to look for these side effects, the ARIA-E and ARIA-H. So this is week 2, week 4, week 6, week 8, etc. So every 2 weeks getting a treatment, and then MRI at baseline, and then MRI 5th, 7th, 14th infusions, and then probably every 6 to 12 months after that. Plus an MRI if there are any new symptoms that may develop, such as the symptoms of ARIA, such as headache or new neurologic signs or symptoms, visual problems, sudden worsening of confusion. And you can see this antibody is given intravenously every 2 weeks during the course of the treatment, and we don't really know how long to go for. We don't have any stopping rules about when to discontinue the treatment. And if the ARIA-E or ARIA-H should develop, if it's mild and not causing any symptoms whatsoever, we can continue treatment and just monitor with an MRI scan every 4 to 6 weeks. If it's severe in either symptoms or severe on the MRI scan, we would stop the treatment immediately and never restart. And if it's in between, then we would hold the dosing, suspend the dosing, and then monitor clinically and monitor by MRI scan. And then we would have a discussion about whether to restart the medication or not. So lots of monitoring, clinical monitoring and MRI monitoring, looking for these side effects, and then trying to decide whether to continue treatment, stop the treatment temporarily, or stop the treatment permanently if more severe side effects should occur. So to summarize, Leqembi was deemed safe and effective for individuals with mild cognitive impairment and mild Alzheimer's disease. It was FDA approved and covered by Medicare as of July this year. And as I showed you, there was about a 27% reduction in cognitive and functional decline, which was equivalent to about 5 months less decline during the 18-month course of the study. And there has been debate, an argument about whether this is really significant enough. Is this enough difference to warrant the inconvenience, to warrant the risks and the side effects, and to warrant the costs of this new treatment? And that's up to each individual and their provider to decide whether they want to get the treatment and accept this degree of reduction in cognitive decline, accepting the risks, the cost, and the inconvenience of getting the Leqembi treatment. Now, this antibody, lecanemab, is also being studied in a separate study, enrolling people who are completely normal, no cognitive or memory problems whatsoever, but they may have amyloid in their brain, so we think they're along that trajectory that they might develop Alzheimer's over time. And we're looking for volunteers for this study with normal cognition who have amyloid in their brain to get the Leqembi treatment for up to 4 years to see if we can prevent Alzheimer's and mild cognitive impairment by removing the amyloid. So this is called the AHEAD study. It's looking for volunteers now. So even though this antibody is already approved for people who already have MCI and Alzheimer's, this is a separate study asking a question: can we prevent Alzheimer's and MCI in these individuals with preclinical Alzheimer's? So lots of things still pending and in progress. We don't have a final decision yet on whether Medicare will cover the cost of amyloid PET imaging. We think that we will find out shortly that they will cover this cost, and then we can find out if there's amyloid in the brain by amyloid PET with Medicare coverage. But this is sort of still a pending issue. Right now, the only way to get coverage is to do a spinal tap and measure amyloid in spinal fluid to prove amyloid positivity. And then we also, everyone should know their ApoE genotype, ApoE genes before starting treatment. It's not absolutely necessary, but to get better information about the risks of ARIA-E and ARIA-H, we would recommend getting ApoE genotyping, and this also is not yet covered by Medicare and costs about $300 to find out the ApoE genotype. There's a study going on to see if an injection of the antibody subcutaneously will work just as well or maybe even better than intravenous. And that would make life easier for everyone to give a subcutaneous injection versus an intravenous infusion. And we're collecting results after the double-blind part of the study that showed benefit. It's called the open label extension, where everyone gets treatment, to see if those curves will continue to separate or not. We're doing a lot of work looking at plasma biomarkers, looking at biomarkers in the blood, the so-called blood test for Alzheimer's disease, to see if we can get away from PET scans and spinal fluid testing completely and just look at blood levels of amyloid, for example. And as I mentioned, we're trying this antibody in a prevention study. It's called the AHEAD study. And is it lots of unanswered questions? Could we monitor amyloid burden with perhaps blood tests or PET scan? For example, could we stop the treatment once the amyloid is removed from the brain and then just monitor to see and then restart the treatment once it starts reaccumulating? You know, we don't really know the answer to that as yet. There are lots of other anti-amyloid antibodies in the pipeline and other strategies and other ways to maybe perhaps treat Alzheimer's disease in addition to these new antibodies, which would lead to new combinations. So there's still quite a lot of work to do and quite a lot of things still pending. I don't really know of anywhere or anyone who's quite ready yet to begin the Lecanumab treatment. I think many places are close. I think Dr. Bixel at his practice in Virginia was the first person to give Lecanumab as a treatment about 2 weeks ago. So we have had one starting already, and I anticipate lots of other places starting treatment with this antibody in coming weeks and months as we all gear up for this. It's a relatively intense treatment course with an IV treatment every 2 weeks, a lot of monitoring with MRI scans and clinical visits. So it's quite intense for not only for the patient and the family, but also for the providers to set all of this up. So this is our contact information. This is me. This is my email. As far as setting up an appointment for evaluation, you can contact Carolyn Ward. This is her email address. This is her telephone number. Again, this is our website. And if you want to know more information about the drug, go to this website, leqembi.com, where there's much more information, including everything that I've said today during the course of this seminar. So I hope we have lots of questions.
We do have lots of questions that have come in. A couple of the questions are related to donanemab. Could you talk a little bit about, would you wait for donanemab? Would you start Leqembi? Are there any benefits of Leqembi over donanemab?
Yeah, donanemab is another anti-amyloid monoclonal antibody. The results came out recently and also showed a slowing of cognitive decline and slowing of functional decline in the treated group compared to the placebo group. Maybe slightly more effective in removing amyloid and having a little bit more of a clinical benefit compared to Leqembi. But this also comes with a higher cost of more side effects. And in fact, in the Leqembi study, there were no deaths as a result of the antibody treatment. But in the donanemab study, there were 3 deaths as a result of the antibody treatment. And these deaths were, two out of the three deaths were related to a hemorrhage that turned out to be fatal, ARIA-H that was fatal. So donanemab may be slightly more effective, but also has more risk than lecanemab. So I anticipate that it will be FDA approved despite these two deaths out of the 1,800 or so who were treated. I still think it will be FDA approved as another safe and effective antibody for treatment of mild cognitive impairment and early Alzheimer's disease. And it may be slightly more effective, but as I said, has higher risk than lecanemab.
Thank you. Another question, do we feel that supplements or specific activities could halt or prevent dementia beyond the established activities for neuroplasticity?
Yeah, that's a great question. I think if you live a good life, a healthy life, you could probably delay Alzheimer's disease by 5 to 10 years. And these are things like maintaining ideal body weight throughout life so that you don't get diabetes and obesity. Exercise, Mediterranean diet with olive oil, and no smoking, trying to avoid or prevent traumatic brain injuries, getting adequate sleep. There's a whole list of things, and we have those on our website. It's called the 4 Pillars Program. So you're welcome to look at that. But there are a lot of lifestyle recommendations that you can do to try to prevent or delay Alzheimer's disease. Even after you already have it or have the beginnings of it, you can also continue to delay and prevent or slow the progression. So a lot of physical activity, mental activity, social activity, as much as you can do. All of these things will help slow down the progression of the disease. At the same time, all of these things will also prolong your lifespan. And the #1 risk factor for Alzheimer's is aging. So even if you do all of these things, you might live longer and then run into the issue of Alzheimer's disease. So we still need to come up with treatments once you may get it.
Dr. Turner, do you recommend that PET and lumbar tests are conducted for those showing gradual memory and language deficits over a period of several years, given the costs and lack of facilities to conduct them?
Yeah, certainly start with your primary care doctor and then get a referral to a specialty clinic if you need one and get a diagnosis. Not all dementia is Alzheimer's disease, of course. There's the second most common diagnosis in our clinic is Lewy body dementia. Maybe the third most common diagnosis is frontotemporal dementia. And these have different pathologies, and these new antibodies may or would not be effective for those. So the first step is to get a diagnosis, starting with blood tests, examinations, MRI scans, and then moving on to glucose PET scans or other specialty PET scans that might be available, amyloid PET, for example. Trying to get an accurate diagnosis so you can figure out what the best treatments may be from there.
Tom asks, do amyloids serve any good purpose? In other words, is there any downside to removing them?
Yeah, that's a great question. The parent protein, amyloid precursor protein, certainly has a normal function, a normal role in all cells. And this fragment, that turns into amyloid, we're not sure if it has a normal function or not. It's still debated. It may have some normal function. But certainly when it aggregates into these large amyloid plaques, it acts like a foreign body, just like a splinter would when you get it in your finger. And your body reacts to it and tries to remove it. It sets up an inflammatory response, just like a splinter in your finger. You get inflammation around the splinter. There's a lot of inflammation in the brain from the accumulation of these amyloid plaques. So maybe the soluble form of the protein does have a normal function. We're not sure, but once it turns into these large aggregates, amyloid plaques, I don't think that has any normal function, and certainly sets up a lot of other bad things that happen in your brain that eventually translates into memory problems and cognitive problems and functional problems.
And Elizabeth asks, what about the new Quest Labs blood test to assess A beta 4240 that doesn't assess amyloid in the brain in lieu of a spinal tap?
Yeah, as I said, we're trying to move to blood tests. I don't think they're quite ready yet for prime time. So we're still kind of stuck with the PET scans and the spinal fluid for now until we get more results and more data with the blood test. One of them is the Quest test. There's another one called C2N. And these measure amyloid and tau proteins in the blood and also can give the ApoE genotype as well. So we're hoping to move to blood tests eventually, but it may be a few more years before we do that. And these blood tests are also not covered by insurance or Medicare currently, and they cost about $1,300 for the blood test. So they're out there, they're available, they can be ordered, they're self-pay, and we need more research to try to get to the use of these blood tests instead of the PET scans and spinal taps.
Nancy asks, how much does the medication Leqembi cost?
How much does the medication cost? I think it's not just the medication, but the PET scan, the MRI scans, the clinic visits, the IV infusions every 2 weeks. So I think the total cost may come to about $100,000 a year. This compares to nursing homes, which costs between $50,000 to $100,000 a year. Now, 80% of that would be covered by Medicare. We hope soon also including the amyloid PET scan. But that still leaves quite a large chunk for self-pay or by Medigap or other insurances to cover. There would probably be at least some copay with each visit and treatment and MRI scan. So it is quite an expensive process.
And Nancy also asks, how long is the course of treatment for Leqembi? I think you mentioned there are no stop instructions. So what would people expect if they started?
Yeah, we would start with people with mild cognitive impairment or mild dementia and probably treat for several years. If there were any intolerable side effects, they would be discontinued. If anyone wanted to stop at any time, they're welcome to stop if they choose to do so. We're really not sure when to stop. Now, donanemab took a different tack, and they stopped their treatment when the amyloid was removed from the brain. So that might be, another way to do this is to just treat until the amyloid is removed and then monitor in some way. The amyloid will probably reaccumulate very slowly, very gradually, as it does with aging. But it may take a few years to reaccumulate. So at some point, we may have to figure out how to stop treatment when the amyloid is gone and then resume when it reaccumulates. Because I don't think we could just treat the numbers of individuals that need to be treated every 2 weeks forever. So.
Jimmy asks, what causes amyloid proteins in the brain?
What causes amyloid? It's a protein that's made throughout our lives, and it's made in all of our cells in our body. And normally the production equals the removal, so it doesn't accumulate. But with aging, the removal slows down. And so the production continues and the removal slows down. So it begins to build up and accumulate in the brain, and it begins to aggregate and form these insoluble plaques that we see on the PET scan. And so we really don't know why this happens, but it does, and it happens with aging. And eventually you reach a threshold where the amount of amyloid in the brain causes memory and cognitive problems.
There was a study you mentioned that's currently recruiting, and is there an age minimum in that study?
In the AHEAD study, which is recruiting people who have normal cognition, I believe the age range is 55 to 85. You have to have amyloid in the brain, either by PET scan or spinal fluid analysis to qualify for the treatment. So most people who sign up for the study usually get good news, usually get news that they don't have amyloid in the brain, or they don't have sufficient amyloid in the brain to qualify for the treatment part. And the older you are, the more likely you're going to have amyloid accumulation in the brain. So the age range is 55 to 85, but most people 55 to 65 usually don't qualify because they don't have amyloid or enough amyloid in the brain. So it's really a 65 to 85 range. But it's a way to find out, if you're interested, to find out if you have amyloid in the brain or not. If you joined a research study, there are no costs, there's no billing, no insurance issues. Everything is covered by the research. So if anyone is interested in joining the AHEAD study just to find out if they had amyloid in the brain or not, that's one way to do it. And the study also looks at your ApoE genes. So if you wanted to know your ApoE genes, the study would tell you. If you don't want to know, they wouldn't tell you. So it's a way to get more information about sort of where you are in this process.
Someone asks, do things like hearing or vision decline without treatment cause an increase in amyloid plaques? Does the brain's effort to hear or see better cause decline in cognitive impairment?
Yeah, great question. We recommend that if your vision is bad, to do whatever is needed to get better vision, including glasses or cataract removal or whatever it takes. And the same thing with hearing. So if you have hearing loss, we recommend getting hearing aids and using them, not just to hear better, but to get more stimulation into the brain. You have to keep your brain active, just like a muscle. Anything that deprives your brain of sensory stimulation, either vision or hearing, should be fixed as much as it can be fixed. And so we always recommend using glasses and hearing aids or whatever it takes to get that information into the brain. We also know that social activity is important, and the more physical, mental, social activity you can do, the better. And if you don't have hearing, then that sometimes impacts on your social activities. So we certainly recommend visual aids and hearing aids as much as you can, to fix as much as you can.
Do potential candidates for the new Leqembi study need to live in close proximity to Georgetown?
Well, this study is being done nationwide. So Georgetown is only one of many sites across the country. So you don't necessarily have to live in the DC area to join the study. You can find many other sites across the country, and I think a few other countries across the world. People tend to drive up to 50 or 100 miles to join a study. We would rather not enroll people who are beyond that, just in case that there's a problem or a side effect, and we would like to see them, fairly quickly, urgently in the clinic, or get an MRI scan or something. So if someone is beyond that range, we have enrolled people, but we would rather have them, within 100 miles of the site.
Heidi asks, do any of the over-the-counter products help with memory problems, like Prevagen?
No, unfortunately not. If it did, we would recommend it. I think, a lot of these are just placebo effect, which is temporary. Prevagen is actually a jellyfish protein, and if you eat this protein, your stomach just digests it. So I don't think it would have any benefit, despite the claims. You'll notice that they never mention a disease on the advertisements, because if they did, they would have to be taken down. It just mentions memory loss, and they can get away with that, even though, the FTC or the regulators are trying to go after them, but so far have not been successful. But if any of these supplements worked, the only supplement we do recommend is a multivitamin a day, to make sure you get enough vitamin B12, for example. But beyond that, these other supplements, we don't know yet. Or they're not effective.
For someone who's being screened for memory problems and has a family history, their neurologist sent them for an MRI. What might the neurologist see on the MRI that would help with the diagnosis, or are they just ruling out other potential issues that might mimic dementia?
Yeah, we do get an imaging study of the brain as part of the evaluation to make a diagnosis. It's either a CAT scan of the brain or an MRI scan of the brain. MRI is better, is preferred, but a CAT scan would work. If, for example, you can't get an MRI because you have a pacemaker or you have claustrophobia. It's mostly, with Alzheimer's disease, mostly to rule out other things. And these other things are often multiple strokes. So there is such a thing as vascular dementia. So you can have multiple strokes causing dementia, and you can see these strokes on an MRI scan or a CAT scan. So other things are like hydrocephalus, tumors, other things that can cause dementia, mostly to rule out other things. For a patient with early typical Alzheimer's disease, the MRI is considered normal for aging, meaning that there is some shrinkage of the brain or atrophy of the brain, and sometimes some white matter changes to go along with that. But these are considered changes that are associated with aging or normal aging. So there's really nothing diagnostic on an MRI for Alzheimer's disease. It's mostly to rule out other things, and including vascular dementia and multiple strokes.
Mary asks, what are the options for a patient who was diagnosed with late onset Alzheimer's based on a PET scan and cognitive testing, but was denied entry into the trial because the trial testing indicated he does not have Alzheimer's, but he continues to decline?
If it's not Alzheimer's, then I would ask, what is the diagnosis? We also have studies at Georgetown for early Lewy body dementia, and other places have studies for frontotemporal dementia. Most of these studies are looking for volunteers in the early stage. So once you get beyond the early or mild stage, there's usually no research options, but there are certainly treatment options. So I would encourage finding out the exact diagnosis and treating accordingly. And if the person is in the early or mild stage, then certainly look for research opportunities. You may or may not be interested in enrolling, but at least find out about what opportunities there may be for research.
Mel asks, does severe obstructive sleep apnea contribute to Alzheimer's or dementia, and does treatment help delay?
Yeah, obstructive sleep apnea is very common, and there is a treatment for that called CPAP, sort of pressure. Now, I know it's very inconvenient, and after a while, many people are not compliant with their CPAP and don't want to use it or won't use it. But obstructive sleep apnea alone can cause some memory problems. I don't think it could cause Alzheimer's, but can certainly cause memory and cognitive problems. And this is treatable, it's very treatable. You do a sleep study to diagnose it and treat with CPAP. And often we ask the patient to get treated with CPAP for their sleep apnea and then reassess their cognition to see if there may be any Alzheimer's going on in addition to the memory problems that may be associated with obstructive sleep apnea. So it's one thing to rule out to treat before we can figure out if the Alzheimer's is there or not.
Bonnie asks, can treatment for high LDL with statins or Repatha help prevent Alzheimer's?
Yeah, high cholesterol is common, and many people are on statins, which are effective and relatively safe, and therefore millions of people are taking statins. I think they are helpful for preventing cholesterol buildup, atherosclerosis buildup in the arteries that leads to heart attacks and strokes. So very helpful there, but you have to take the statin for a long time to get a benefit. I don't think, now having strokes can cause dementia, vascular dementia, and then this can sort of lower your threshold for Alzheimer's as you get older. So then you can have a mixed dementia. You can have both vascular and Alzheimer's disease. So the statins can prevent strokes and heart attacks. I don't think it really could prevent Alzheimer's disease, but it may, by preventing the strokes, it could delay the onset of dementia.
We have a few questions about the study that you referenced that's recruiting. What's the best website to go to learn more about that study?
To learn more about that study, you could call Carolyn Ward or go to memory.georgetown.edu. It's also listed in clinicaltrials.gov, and clinicaltrials.gov will list every single site that is doing the AHEAD trial. And Georgetown, as I said, is one of them. And so you can find out more about it and where it's occurring.
And if you have type 2 diabetes, can you still participate in the study?
Yes, the major risk factors for Alzheimer's are number 1 is aging, number 2 is genetics or family history, and a lot of that is the ApoE gene. But number 3 risk factor is diabetes. So there's some link between diabetes and Alzheimer's. Most of our trials do not rule out diabetes to enroll in a study. There is one trial that we're looking at metformin, which is a drug for diabetes, to see if it can prevent conversion of mild cognitive impairment to dementia. And obviously this trial does rule out people with diabetes, but most of our studies do not. So you can still join a study as long as your diabetes is treated and stable.
Joanne says, so in summary, does the drug give you a 1 in 5 chance of slowing your functioning by only about 5 months with chances of serious side effects? It'll cost you a lot of time and effort. Would you take this drug if you were having MCI issues and qualify?
Good question, and each person has to answer that themselves after a discussion between them and their family and their providers. And so each person can make their own decisions about whether they want to accept the inconvenience, the cost, and the risks associated with this antibody. But I know Alzheimer's very well, all too well, and I know what it can do. My mother died of Alzheimer's after 20 years, and I've seen what it did to my family. And so I would accept the inconvenience, the risk, and the cost, and get the Lecanumab treatment. But that's it. That's your own personal decision to make as to whether you would want to do that or not.
Lisa asks, do the risks decline after 3 or 6 months of treatment if you have no swelling or bleeds, if you were taking Leqembi?
Yes, so with all of these antibodies, the risk of ARIA-E and ARIA-H is usually at the beginning when you start the treatments, usually in the first 6 to 8 treatments, and the risk decrease. If you don't have ARIA-E or ARIA-H at the beginning, then the risk decrease over time. So yes, it certainly does decrease. So if you can get through the beginning, first several months without the ARIA-E, ARIA-H, then there's a good possibility you may never get it.
Bruce says, a recent Wall Street Journal article noted that Leqembi patients experienced less than a 0.5 point effect on an 18-point cognitive scale, and that some experts say that for a slowing of decline to be clinically meaningful or noticeable, the difference must be at least 1 point. What are your thoughts on those comments?
That's part of this debate about whether this magnitude of benefit is worth it. And this particular scale was the clinical dementia rating scale. But there is a huge difference between a clinical dementia rating scale of 0, which is normal, or 0.5, which is mild cognitive impairment, or 1, which is dementia. So I think a 0.5 difference is huge. Now, remember, Alzheimer's is a process that takes 10, 20, 30 years, and we're only measuring 18 months. And so we don't expect to see huge changes in 18 months. So I would argue that this is a clinically significant benefit, but again, this is a personal decision, and others argue that this is not enough benefit to warrant the risks, the cost, and the inconvenience.
Chris asks, are there other symptoms that might be an indicator of amyloid buildup in the brain?
Amyloid builds up in the brain 10 to 20 years before you get any clinical symptoms. It usually begins with memory loss, and particularly making a new memory is the first thing to go with Alzheimer's disease. So you begin to repeat questions, you lose things, you can't come up with the right word for something, word finding difficulties, forgetting things. Old memories are fine. Making a new memory is the hardest thing to do. So this is the beginnings of usually Alzheimer's disease. affecting what's called the hippocampus of the brain, which is the part of the brain that we need to make new memories. And this is where the amyloid and the tau pathologies begin. So amyloid can accumulate 10 to 20 years without any symptoms whatsoever. But then eventually it starts to cause these difficulties, usually with memory and especially making a new memory is the first symptom.
Someone asks, how do you rule out the impact of a traumatic brain injury versus dementia alone, other than questioning for a potential TBI from accidents or sports? Do people with TBIs or multiple TBIs have increased risk for dementia?
Yes, any significant traumatic brain injury anytime in life will increase your risk for dementia when you get older. More traumatic brain injuries will increase the risk even more. And you can accumulate enough traumatic brain injuries that you can get dementia just from that alone. And this is called chronic traumatic encephalopathy. And this is what's being investigated in the boxers and football players that get demented, and as well as psychiatric problems, depression and suicide and things like that. So traumatic brain injury certainly is a risk factor for Alzheimer's disease, and traumatic injury by itself can cause dementia, the traumatic encephalopathy that I mentioned. And so we always recommend avoiding traumatic brain injuries, and these are doing things like wearing seatbelts when you're driving and wearing helmets for certain sporting events and cycling, for example. When you get older, there are things to avoid traumatic brain injuries, such as fall prevention, getting physical therapy, using canes or walkers or whatever is needed to prevent falls and brain injuries. So certainly traumatic brain injury can perhaps trigger or accelerate or add to the dementia of Alzheimer's disease.
Someone asks, does a bilateral knee replacement disqualify me for an MRI?
Bilateral knee replacements are fine with MRI scans. These are fixed objects. They're not going to move for an MRI scan. The things that move are the things that are problematic. For example, if you had a little bit of shrapnel somewhere in your body or perhaps in your eye, that would be a problem. If you had a pacemaker, that would be a problem for MRI. But new knees and other new hips and things like that is not a problem.
Catherine asks, are the MABs that you're discussing the same or similar to those used to treat COVID?
There are lots of antibodies that are given for lots of diseases, and these antibodies are similar to those given for COVID and lots of other diseases. It's just the question is, what does the antibody stick to, or what does it recognize? What does it bind to? For the COVID antibodies, the antibody is designed to bind to the COVID virus, and for Alzheimer's disease, the antibody is designed to stick to the amyloid plaque. And when the antibody sticks to these things, the immune cells recognize them as foreign and try to remove them and get rid of them and degrade them. And so that's how these antibodies work.
If someone could afford the Quest blood test, would you recommend that they take it?
It could be useful as a screen. It's self-pay. It's not covered by Medicare or insurance, and I think it costs about $1,300 or so. For some of our research studies, we do use the blood test as a screen to determine who then goes on to the amyloid PET or the spinal tap. So if the blood test is negative, then there's a very good chance that the spinal fluid and the amyloid PET would be negative, and there's no point in doing those. So for example, the AHEAD study, the first visit is a blood test for Alzheimer's disease. It's the C2N blood test. And if that's negative, then that's good news, and people are finished with the study, because if they went on to get an amyloid PET or spinal fluid, it would most likely be negative. So it is useful as a screen, but as I said, it's not a perfect study yet, and we still need to learn more about it before we can really use it to replace the PET and the spinal fluid.
Is there a specific blood test that would determine abnormal levels of amyloid? And if so, what is it called?
Yeah, there are a couple of there's a lot of blood tests in research. I think there are a couple that are commercially available. One is the Quest and one is C2N. And these measure the amyloid proteins in the blood and tau proteins in the blood, particularly a phospho-tau protein in the blood, as a measure of trying to get at a measure of the pathology in the brain without actually doing a PET scan or spinal fluid analysis. And the spinal fluid also looks at the same proteins, the amyloid and the tau proteins, among others.
If you qualify to enter the study, could you be assigned to the placebo group and not get treatment?
Yes, all of our research studies, all of our clinical trials have a placebo group. Some of them are 50-50 and some of them have better odds, like 1/3 chance of placebo. It depends on the study. But the only way we can prove whether a treatment is beneficial or not is to have a placebo group. And so, for example, the Lecanumab study was 18 months of placebo or drug. But after that 18 months, everyone was offered the real drug. And this is called the open label extension. So we have lots of people getting lecanemab in the open label extension part of the trial. So they may or may not have got placebo for 18 months, but then after that, everyone gets the real drug.
And we have 2 remaining questions. The first from Susie: do treatments to thin blood, like a baby aspirin or Plavix, help with Alzheimer's symptoms?
Plavix and aspirin are more designed to prevent stroke and heart attack. And as I said, you can have strokes that cause vascular dementia, and then that can sort of lower the threshold for Alzheimer's disease. So then you can get a mixed dementia, Alzheimer's plus vascular. Aspirin, Plavix themselves, I don't think really affect Alzheimer's directly. And then there's also a question of anticoagulation with the antibody. We think aspirin and Plavix and antiplatelet drugs like that are okay. They don't seem to increase the risk of RAH, but blood thinners do increase risk of the RAH hemorrhage. So if someone is on a true blood thinner, not just aspirin or Plavix, then we would recommend not getting the lecanemab.
And the last question from George, he says, sorry if this has already been asked and answered, and I joined late, but for the new Leqembi therapy, do only early Alzheimer's patients qualify? And if so, what's the difference between early and advanced Alzheimer's for the purposes of qualifying for the treatment?
Yeah, the drug has only been studied in people with mild cognitive impairment and early Alzheimer's when they enrolled in the study. And early Alzheimer's means mild, meaning that there is some impairment in functional activities, but not severe. So maybe having difficulty handling finances, driving, taking medications, appropriately as prescribed, things like that. But certainly having no problems with basic activities of daily living, such as dressing, bathing, grooming, walking, toileting, transfers, eating, things like that. So basically in the mild stage, and we have a test called the MMSE, the Mini Mental State Exam test, where a perfect score is 30. To qualify for Leqembi, you'd have to score between 22 points to 30 points to qualify and have a diagnosis of mild cognitive impairment or mild dementia due to Alzheimer's. But once you advance to the moderate stage and score less than 22, then probably would no longer qualify for lecanemab.
Thank you so much, Dr. Turner. You've been
Thank you.
amazing with answering so many questions that have come in, and we know how many people this disease touches. And so thank you so much for being here to share information and support everyone.
You're welcome.
And I will send out the Dr. Turner slides to everyone who registered for today's webinar. And you are welcome to utilize Dr. Turner's email address, which is on the front of his slides, or to contact us at Insight with questions that you might have. Insight does have a variety of programs to support people with early stage memory loss and other cognitive impairments, as well as their families. Some programs, like the SHARE program, are for couples and are a care planning program to really understand the diagnosis and think about planning for the future. Reconnections is a program that meets here in Northern Virginia in person, and it is a peer support social brain health program for people with early stage dementia. There are a variety of different support groups that meet in person and online. Some are specific to people with MCI or early stage dementia or their care partners. And Insight always offers free consultations no matter where you are, and you are always welcome to contact us. You can follow us online to see what we're posting, different articles, blog articles, upcoming events, new programs that are being offered. And if you have any questions, please call us at Insight, visit us online, or I'm Lindsay, the Director of Early Stage Programs, and I invite you to email me at your convenience. So thank you everyone for being here with us today, and especially thank you to Dr. Turner from Georgetown and to AARP Virginia for sponsoring today's class. So everyone have a great day.